Across this knee osteoarthritis series, we've covered what's happening in the joint, flare-ups, injections, and whether OA is progressive. So in this video, we're looking at when surgery is actually considered. Drop a comment down below if you're considering a total knee replacement.
So let's get right to it. This is probably the question on a lot of your minds. You get an x-ray, the report comes back, and it's filled with these kind of scary words, right? Degeneration, narrowing, bone spurs, and it's so easy to immediately think, well, that's it. I guess I'm headed for surgery. But is that actually the case?
Well, here's the good news. For the vast majority of people, the answer is a big, clear no. The evidence on this is overwhelming. A bad x-ray is absolutely not a one-way ticket to the operating room. So let's dive in and unpack exactly why that is.
Okay, so it all comes down to this really important concept that clinicians call the symptom imaging mismatch. It sounds a bit technical, I know, but the idea is actually super simple. It just means that what we see on a picture, like an x-ray, doesn't always match up with what a person is actually feeling in their day-to-day life.
Think about it like this. An x-ray is just a snapshot of the structure of your knee. It's great at showing us things like, if the space between the bones has gotten smaller, or if there are those bony growths we call osteophytes. But here's the kicker. Those are just structural changes. And what the research shows, pretty surprisingly, is that there's a really weak link between those changes and your personal experience, your pain, your stiffness, or how well you can actually get around.
And this right here, this is fascinating. This data comes from a really important study. And just look at those massive ranges. For people who have knee pain, the number who actually have OA on an x-ray is anywhere from 15% to 76%. And then flip it around. For people who have clear OA on an x-ray, the number who actually feel pain ranges from 15% all the way up to 81%. It just shows there's this huge overlap. You can literally have an x-ray that looks like a war zone and be out playing golf with no pain, or your x-ray could look almost perfect and you could be in real agony.
So this quote from the researchers really hits the nail on the head. The bottom line is that we shouldn't be making huge decisions, especially about something as big as surgery, based only on an x-ray. It's just one tiny piece of a much, much bigger puzzle.
Okay, so if the x-ray isn't the main trigger for surgery, then what is? Well, before we can even answer that, we have to talk about what comes first. Because here's something that's absolutely crucial to understand. Every single major clinical guideline out there agrees on one thing. Surgery is never the first step.
Instead, the real foundation of care for absolutely everyone with knee osteoarthritis comes down to these three core things. First is education, so you actually understand what's going on. Second is therapeutic exercise, which is all about strengthening your muscles and just getting your body moving. And third, if it's appropriate for you, is weight management. And I really want to stress this, these are not just things you do to kill time while waiting for surgery. No way. These are powerful evidence-based treatments in their own right.
In fact, the standard of care is that you should give these non-surgical approaches a really good go. We're talking at least 12 weeks of consistent optimal care before a surgical referral is even on the table. It's all about giving these foundational treatments a real chance to work.
All right, so let's say you've done all that. You've really committed to those core treatments, and you understand that the x-ray isn't the whole story. So what is the real tipping point? What is the one factor that actually moves the conversation towards surgery?
The answer is all about your quality of life. The decision is really driven by your function. Is your pain consistently waking you up at night? Are you finding you just can't do basic daily things like walking or getting up and down stairs? Is it getting in the way of your work, your hobbies, or your social life? When the answer to these questions is a big yes, and these problems just won't go away, despite your best efforts with non-surgical care, well, that's when the conversation might begin.
And clinicians can actually get pretty objective about this. This table uses a common tool called the Oxford Knee Score, which basically measures your function. And look at the clear link here. The lower your function is before surgery, the higher your chances are of a meaningful improvement after. If your score is 23 or less, you've got a 90% or higher chance of a significant benefit. But look at the other end. If your function is already pretty good, a score over 41, the chance that surgery will make a big difference drops to basically 0.
Now, it's important to know this data isn't used to create some kind of hard cutoff. It's really there to help inform a crucial process. Because the final choice about surgery, well, it's not made for you, it's made with you.
And this brings us to this idea of shared decision-making, which is really a cornerstone of modern healthcare. It's all about partnership. Your clinician brings their medical expertise, the facts, the risks, the benefits, and you bring the most important part,
your personal values, your life goals, and what you're really hoping to achieve. And together, you make an informed choice.
And this is the explicit goal of the medical guidelines. As this quote says, their whole purpose isn't to create a rigid set of rules. It's to give doctors the information they need to have that exact kind of collaborative, shared conversation with you.
Part of that conversation involves one last, absolutely critical piece of the puzzle, and that's making sure that what surgery can deliver actually matches what you want and expect from it.
Because here's a statistic that might surprise you. Even though knee replacement is a technically successful operation most of the time, research shows that about 1 in 5 patients are not fully satisfied with the outcome a year later. So why is that?
Well, it turns out that satisfaction isn't just about the mechanics of the new joint. The strongest predictors of whether a patient will be happy with their outcome are things that exist before they even get to the operating room. Having unrealistic expectations about what the surgery can do, and the presence of things like pre-existing depression or anxiety.
And here's a really subtle but important finding from the research. Total knee replacement is excellent, truly excellent, at reducing pain that is specific to your knee and improving your knee function. However, it may not cause a massive shift in your overall general health-related quality of life. And that's because our overall well-being is influenced by so many other factors beyond just what's happening in one joint.
Which brings us to the final and I think the most important question. This is the one to really take with you. Before you even think about surgery, you need to clearly define what success actually means to you. Is it being able to walk to the mailbox without pain? Is it getting back to gardening? Is it simply sleeping through the night? Defining your personal goals is the most powerful step you can take in making the right decision for your health.